Hello, I'm Linda Gask and I'm the RC Psych lead for primary care and community assets. I'm talking to you from my kitchen in Orkney, and this evening we've got a meeting which is about, it's a case discussion, a collaborative case discussion in 4 sections. There'll be a 10-minute conversation between a psychiatrist and a GP in each section, and then 5 minutes where we'll have an opportunity to address some of your questions. So please get the questions coming in. I'll let the presenters introduce themselves, but we have 3 GPs and 3 psychiatrists. So over to Carolyn, I think, for the first session.
Hello, I'm Carolyn-Chew. I'm a GP in Manchester and an academic at Keele University. Can we have the first slide, please? So we want to base this webinar around a case, and that's Mr. Patrick O'Neill. He's 82 and he was widowed 3 years ago. He has an adult son who lives in London and a daughter who lives in Somerset, but another son died 6 years ago from lung cancer. He's got good neighbours and a niece lives 2 miles away. He's got COPD, hypertension, heart failure, multimorbidity. And the care that he thinks he gets from the practice is really from his healthcare assistant and practice nurse. Doesn't really know who his GP is. Depression is common in older adults and can coexist with anxiety. Both anxiety and depression are common, particularly when people have long-term physical conditions, as with Patrick here. Older adults may not recognise that they have a problem. They may not think it's appropriate to bring distress to the GP. They may have that stiff upper lip, and there may be some stigma associated with mental health problems or distress. But depression is really important to identify because it can increase the risk for increased morbidity and mortality from long-term conditions, as well as increasing the risk of hospital and care home admission. So I'm going to hand over to Suhana, and we're going to have a conversation about Patrick.
Hi there. For those of you that don't know me, my name is Suhana Ahmed. I'm a consultant old age psychiatrist in the southwest of London, also director of medical education. I work on an older people's inpatient ward. I've also had CMHT experience. So we know that depressive symptoms occur in up to about 25% of older adults with physical health problems. So I guess as GPs, this is a large proportion of the people we see. And I guess what we do know from Carolyn's work is that older adults with depression do respond to psychosocial interventions such as behavioural activation. And I guess what I would like sort of to ask you, Carolyn, is to tell us just a little bit more about that, because that is sometimes forgotten about in this age group.
So I'm going to just mention what behavioural activation is. Behavioural activation, or BA, focuses on addressing the behavioural deficits that are common amongst those with depression. So it attempts to reinforce or reintroduce the positive reinforcement of functional behaviours, and it reduces avoidance. And to work with a patient or an older person who's depressed with using behavioural techniques, you don't actually need to mention mental health or depression, so that you lose the stigma. And people can be encouraged to identify and reintroduce valued activities that they've stopped doing, or ones that they'd like to take up. And that's an important component of behavioural activation that actually can be done in general practice consultations. And I've worked on a number of trials where we've shown that behavioural activation is actually helpful for older adults with depression. And I've also worked on the SHARD trial where we showed that older adults who'd got subthreshold depression, using behavioural activation delivered by sort of self-help materials, could actually prevent the movement towards depression.
Thank you, Carolyn. That's really helpful to know, especially about the trials. I guess as a psychiatrist, what would be helpful for me to know is how might depression be identified in primary care?
Okay, so depression and anxiety can be identified opportunistically using the case finding questions. These are 2 questions that are used to identify depression and 2 for anxiety. And they are the first 2 questions on the PHQ-9 and the GAD-7. And I suppose it's important to get to know what these questions are and to start to use them in consultations with older adults, but also not to be afraid to ask the question and not fear opening up the Pandora's box. And obviously, if people answer positively to 1 or 2 of these on each of the case finding questions, then it's important to explore feelings a little bit more and perhaps move to the PHQ-9 or the GAD-7 to try and identify the severity of the condition.
Thanks, Carolyn. Again, that's really helpful. I guess I'm very aware as a psychiatrist, I don't see sort of the end of the spectrum that you see a lot of the time. So the mild and moderate depressions, and I guess even some of the severe people. I see, some very severely unwell people, and NICE guidance suggests that, we use our assessment of the patient. So like you said, the PHQ, the GAD-7, to identify management options in a sort of stepped, cared way. And obviously as a GP, you play an important role in that. And I wondered how, you went about sort of identifying initial management. So I know that you've advised about sleep, activity, exercise, diet and alcohol, but at what point would you refer to IAPT?
Okay, so I guess I would bring it up when I identified that somebody had anxiety or depression and talk to them about what the options are. But IAPT is important to consider. IAPT is improving access to psychological therapies and resulted from a massive investment in 2008, offering psychological therapies including cognitive behavioural therapy, behavioural activation, counselling, and the therapies are doing delivering either counselling or other psychological interventions. And I think if an older adult was willing to be referred, then I would suggest that as a first line. And I think there's quite a lot of evidence that actually older adults don't refer themselves, but also GPs don't always offer referral. They don't think that older adults will perhaps find psychological therapies acceptable. However, we've also now got social prescribing resources and services. So it's really important to think about those as options, particularly for people with mild depression or with social isolation and loneliness, because again, they may be more acceptable to older adults because they don't have the mental health label to stigmatise them. Suhana, I wonder if you can just talk through what is the role of antidepressants in the management of older adults with depression and anxiety?
I think that's a really helpful question, because a lot of the time, especially when I was working in the CMHT, they were questions that GPs would ask. And I think, like you've identified about the psychosocial and psychological interventions being a big part of the management, I think medication in terms of antidepressants have a large role to play as well. We know that depression and anxiety is very debilitating, and in this age group, we find that it can deteriorate very, very quickly into something that is a lot more severe and difficult to treat. And I hear lots of my sort of primary care colleagues saying, that they avoid antidepressants because of polypharmacy and side effects. And what I would say to them is if an antidepressant is indicated, I would use it. We know that they work very well and they are effective. And by going slow and gradually, I think you mitigate those risks. So I would very much encourage people in using them when they need to be used, as they are very effective.
A problem I often need help with is when an older person has perhaps not responded to do different antidepressants, perhaps had some psychological therapies. And is that a situation where I could refer to an older psychiatrist for some help?
I think it very much depends on the patient and the other circumstances around it. I always find with people like this, it's worth looking at the reason why they haven't responded. So things like compliance, is there an underlying memory problem? Are there maintaining factors? So usually there is a reason why they haven't responded.
So perhaps I should explore that fully before thinking about referral. That's really helpful, thank you. Okay, we've finished now.
I'm going to move on and ask the questions. We do have one question which I think has been answered already, but I think it's really good to bring it in. Tips on getting an older person to recognise or accept they have a mood disorder. I often find patients decline or deny this diagnosis. I think that's, I remember when we were doing a big study in Manchester, it was really quite a problem whenever you mentioned depression or mental health or any topic like that with patients with older adults. So would either of you like to say something about that?
I'm happy to say from a GP perspective, and I guess this is where if I think somebody is depressed or anxious, down, distressed, I will try and explore that with them, asking, reflecting perhaps how they look, getting them to talk through what's going on and try not to medicalise their problems. But I think if I was really struggling, I'd probably use the PHQ-9 and work through that with them, because often a patient, an older adult might come in saying they feel tired all the time, or they feel that they want a tonic. And so I'll go down the PHQ-9 questions with them and then reflect when the score's perhaps 18, say, well, actually, having done this and you've told me all about what's going on, it seems to me that you're depressed. What do you think about that? And see what their response is. And their response may be no, and then I'll talk to them about what depression is and why, try and discuss with them why they think they're not depressed. But if they might reflect on that and say, but I don't want tablets, then we'll think about the other options like social prescribing and like improving access to psychological therapies. And if I really hit a brick wall, I'll say, okay, well, let's leave that for the moment. Let's see what else we need to do. We might need to do some blood tests, particularly if they're presenting with physical symptoms. But I will follow them up. And so develop that relationship with them so that then I hope the next time I see them, we can explore whether there's a mood problem next time.
I can't see any other questions. So I think at this point, I'm going to suggest that we move on. There's a possibility we may have more questions in the next section. Is there anything else that either of you would like to add before we do that?
I guess what I would like to add is just in response to that question is sometimes family can be very helpful. So family and relatives, the partner, the daughter, the son, especially in that sort of older generation where there is lots of stigma. So it's worth, if you are able to, thinking about involving family if they are consenting. So that's the only thing I would add.
That's great. Thank you very much, both of you. We've moved on already to the next part of this case. We're going to reveal a little bit more information in each 15 minutes. So we now have the next piece of the information. You can stay on this slide, and I'm going to hand over and ask Ruth to introduce herself now.
So, hello, I'm Ruth Thompson. I'm a GP in Ancoats in Manchester. And this for a GP is a very common scenario. We get, if we encourage people to screen, then we have to accept that there'll be a lot of people screening and asking questions about low mood that aren't really fully equipped to maybe hold that level of risk. I think particularly about PWPs, the voluntary and community sector, social prescribers, and our own primary care staff. And as GPs, we have to be very willing to take that risk from people when they do screen, and encourage them to screen and encourage them to speak to us about this. This is a difficult scenario because this gentleman attended today to talk about his breathing, and actually we've completely moved the agenda. And as such, I might not fully be able to do a full risk assessment, but I would want to start the risk assessment process. And I think that's one of the things that we have in general practice. It's quite useful, is longitudinalness, if that's a word. You know, we can see people today, tomorrow, we can phone them at the end of the week. We see people quite often as necessary. And then the other thing that we have in primary care is that holistic knowledge. And as Suhana was talking about, it's important to start thinking about family and gathering information. So one of the key things that I would do as a GP is actually talk to Patrick, Mr. O'Neill, and ask him if he minded if I contacted some of his family members to talk about how he's getting on and just to see what his response is. Obviously, if he declines, then that becomes quite tricky. There is some new guidance that's just come out. It's called Share, which I'll post a link in the announcements about how we speak to family members and what knowledge we share and when we share it. I'll also post in the thing a YouTube set of videos that I've done for primary care doctors, because risk assessment is a big topic. And I suppose we do manage a lot of primary care risk. And I suppose my question to Suhana would be, when do you think that we should be starting to get secondary care involved? What do you think?
Thanks, Ruth. And that's the critical question, isn't it? Because I know that you have those consults on a 5 o'clock on a Friday where someone comes in and tells you, something you're not expecting to hear. I think sometimes what I think about is risk in short term and long term, and it's worth thinking about risk in that sort of sense. And when I say risk in short term, what I'm talking about is immediate risk. So the next 24, 48 hours, 72 hours, can you ensure that this patient is safe in that time? If you can't, then you need to be making an urgent referral to mental health services. If you know that short-term risk is moderate or low, but the long-term risk is really high. So this is not in this case, but in different cases, younger people who have made various suicide attempts in the past. That's a bit different because that's a longer term risk and it's not something that you have to deal with on a Friday afternoon per se. So I think it's really important to make that distinction. I guess the other thing I'd say is risk is very different in the elderly. So the ones that you would expect in someone younger may not be the case in someone that is elderly. So things like vulnerability, things like self-neglect, those sorts of things, safeguardings, are sort of so that the risks are broader and not as predictable. I guess what I would like to ask you, Ruth, is I guess how you manage. You have a 10-minute consult with a lot of these patients, and I wonder how you manage sort of that your feeling and your anxiety around that risk.
So our consulting has changed completely post-COVID. We no longer have, many GPs no longer have fixed sessions with lots of slots of face-to-face. We are doing so much by email, so much by phone, and so much by various different texting. And we do an awful lot now without actually seeing a patient. So I can go through a day and maybe only see 2 patients. So in a way, for me, having somebody come into my room and have a face-to-face consultation actually feels like old style GP, and I would probably actually quite enjoy it because we work in such a different way now. It's much more transactional a way and much less about relationships, I think. And that's come from COVID and all the different changes in technology. So actually, we're not necessarily as limited by times as we were. We will have a workload sitting there, waiting there, different things ping in via these different technologies. So Accurix, Foxfall, DocMan, all the different things are pinging. But actually, to have somebody in my room, I can probably put that at bay. but you're right, I wouldn't be able to do a full hour. I'd probably do 10, 20 minutes. And it's really to get the actual, the nub of the problem. And does this man want to talk about this today? Because as I say, it's not really the agenda he necessarily was expecting, and it may be that we're just going to tentatively broach. Obviously, I would say thank you very much for sharing with us, and that we do want to know, and we're keen to find out this sort of information and how he's feeling, and he must be willing to talk to us. But he might prefer to delay until next day, day after, in which case that would be, I think, a reasonable thing to do. We can't force people to share difficult information, especially if they've been living with it for a while and it's just become part of their thoughts. I would want to make sure that, as you said, there's no acute sort of risk, that he hasn't a plan for tonight, and that he's not actively made preparations to say goodbye or leave notes or things. But if it's anything less, then I would probably start to broach. And I want to do information gathering as well, because that's very important. And I suppose that's my question would be back to you, is how much information would you want from us if we were to start asking to share the risk? And notice, I think it's quite important that we talk about shared risk, and I think GPs need to be aware that even if people aren't sort of necessarily accepted by secondary care, even if we've spoken to a secondary care consultant, we have still shared the risk, and it's that shared risk management. And then the other question for you is, what else do you bring in terms of the sharing of the risk? What particular skills or things might you have that we don't have in primary care that help you to make a very complete risk assessment?
Thanks, Ruth. That's really helpful. I guess, you know, we talk about risk, and I guess we have, as psychiatrists, more time than you would do in a GP consult. We have the option of someone following them up regularly if we do think that they are at risk. You know, we have things like home treatment teams, obviously, that go in every day. So there is that sort of thing. I guess what it's probably worth noting, and I say this to my primary care colleagues a lot, you can do the best risk assessment in the world. You can spend hours sort of gathering information and so on and so forth. But the reality is, it's, you know, sometimes it just isn't enough, and people are unpredictable and situations are complex. So although you have done that very detailed risk assessment, it's not always a predictor of what happens next. And you talked about sort of the shared risk, and I think that's a really good point. And I think it's important to think about what is in your control when you see a patient like this. So what is in your control is making a referral to secondary mental health services. What is not in your control is whether that referral is accepted or not, but you have made that referral. So, for example, if this, you know, God forbid, if something awful happened, this went to a coroner's court, you have made that referral and you've tried to share that risk. You know, what is in your control is asking the patient for more information. What is not in your control is the information they give you and whether that is accurate or not. And I sort of find even, you know, doing it the way I do it, trying to put it in that sort of way helps you feel less anxious, you know, less frustrated. So that in itself is sharing of risk, doing that referral, but not having it accepted. You have still done that referral. And I guess the other thing to note is, you know, it may be that you just need advice sometimes. So specify that, you know, if it's a phone call that you need, and this is why liaison between us and yourselves is so important, because, you know, that sharing of knowledge, it may just be a phone call and an advice that you need on that Friday afternoon. So that would be my response to that question, Ruth.
Lovely. I think that's really helpful, and it does help us. I think you just touched on that feeling, how this makes us feel. And that's really important, isn't it, that we recognise ourselves that it's likely to make us feel anxious, and we might feel quite alone. I'm lucky to work in a big practice with lots of supportive colleagues, so I probably would speak to a colleague locally here, one of my GP colleagues, if I was feeling at all concerned. And it is important that we share that, and self-care, because we don't want to be spending time with our friends and family worrying about patients, because we need that time ourselves so that we can rest and recuperate, so that we can be well for our patients for the following week. And so that's really important to acknowledge how that impacts on all of us, really.
I'm going to stop you there and
okay.
move on. We have a question, which I think is a really good one. Sometimes a patient expresses nihilistic thoughts, but not particularly suicidal thoughts, especially when very elderly with multiple comorbidity. Is the risk of suicide still high in this scenario?
I can start to answer this one, Ruth, and then it would be helpful to get your input into it. I guess what I would say to that is, yes, I think the risk would still be high, because I think what you have is you have how someone presents to you, and then you have, you know, those things that you know, and the demographics. So you know that people who are isolated with lots of physical health problems, you know, who are elderly, who are male, have an increased risk of completed suicide. They use violent methods. So I think even if someone is not telling you that, I think the demographics tell you that. You know, and I think it's important to use both of those in conjunction. And if you were to refer someone to me with those demographics who wasn't saying they were suicidal, I would still take that seriously. I don't know if you wanted to add anything to that, Ruth.
I just think it's important that we can have honest conversations with patients at this sort of age, because I know that people are thinking about death a fair amount. They've often seen a lot of their friends and siblings die. And so in a way, a conversation about death is not necessarily the same as it would be with a younger person. I think once of a lady, I had to go out and try and persuade her to start warfarin to stop a stroke. And she kept saying, but will it be quick? Will it be painless? Because actually, though she didn't want to die, she did want a quick and painless death when it came. And so it's talking about death is different, I think, in older people, especially if they've witnessed quite a lot of death. And it doesn't have to be, and I think it's probably quite difficult to assess what is nihilistic, as in a bleakness, rather than an honest conversation about what a good death would be for that person. And so it is very difficult to sort of assess. But nihilism, I would, the lady who wanted a quick and painless stroke was actually when she was still writing to her daughter. She had things to look forward to. So it wasn't a nihilistic conversation about dying. And I think that's probably the telling thing, isn't it? What else is going on in their life? But yes, it is a much more difficult conversation, I think.
Anything else you want to add, Suhana?
No, I just think it's really important. And I think it was, I can't remember who it was, Carolyn or Ruth, that talked about it, about looking at a patient holistically, you know, and in context, like Ruth says. So, you know, older people do say, you know, talk about being ready to go and so on. So it's putting some context around it. But if, you know, with so many of these cases, I go with instinct and gut feeling. So, you know, if you know this patient, and if you know something isn't right and they're not sounding like they usually do, go with that instinct, go with that gut feeling, you know, because I find that 9 times out of 10, it's right. And you'd much rather, you know, that 1%, you know, that 1 out of 10 be referred incorrectly than, you know, missing it all those other times.
I think the what as an adult general psychiatrist, what would really worry me was if there was evidence of psychotic depression, and if that person really had nihilistic delusions about themselves. I'm thinking of people I've seen who, you know, believe that there's no point in drinking or eating because there's, you know, their body has disappeared inside, and all sorts of, or that they've caused, they're responsible for some calamity. So if people are having those kind of psychotic delusions, then I would certainly be very, very concerned about risk. I'm going to move us on at this point, and thank you very much, both of you. Ruth is staying with us, and we're now joined by Tony. Tony, would you like to introduce yourself, please?
Yeah, hello everyone. I'm Tony Rao. I'm a consultant old-age psychiatrist. So I used to work in the community for about 22 years as a care coordinator for half of that, actually. So a lot of contact with GPs. I now work in a specialist dementia care unit where I'm seeing, unfortunately, I'm seeing the sort of tail end of people who've made their journey through the NHS, and unfortunately, some of them have. Oh, hold on. Can you hear me?
Yes.
Yeah, sorry, there's a connection problem. Yeah, some people obviously have succumbed to the effects of alcohol, and it's very important. This is the time when I said about a few years ago that I don't want to be in a position now that I was in 20 years ago, when old age psychiatry services were simply refusing to see people who drank. And we ended up in the situation that there was a downward spiral, and that people ended up in a position where they became dependent and then lost their ability to really rationalize their alcohol intake. So just a bit of background to this, that over the last 15 years, we have seen that older people are the fastest growing population, particularly the baby boomer generation, who are drinking to damage their health. So whether you look at drinking over low risk limits, whether you look at alcohol related deaths, whether you look at hospital admissions, it all triangulates into a whole, and that is that this population is at increased risk. So I want to start off by saying that Mr. O'Neill will say that he likes a tipple, but the problem is with this, that the shame, the stigma, the guilt, and all the other problems and the kind of low self-esteem that go with admitting that you've got an alcohol problem do cause that person really to put the stumbling blocks upon themselves. So when they're sitting in the GP consult for 7 to 10 minutes, it's really difficult for them to own up. So I suppose I would ask Ruth in this instance that were Mr. O'Neill to be sitting in the chair and saying he likes a tipple, how would you progress from there?
I think very similarly, I would absolutely want to know if there was any family input at this point, because people often see things, so family members might have seen things that the patient themselves hasn't noticed, but only with patient consent. And the other thing that I think we haven't yet touched on is how we ask questions. And I particularly like when we normalise questions. You know, it's become very common during COVID for people to drink a little bit more than they usually do. So would you mind telling me a little bit more about that? And so we've normalised the context that we're all changing our behaviours because of COVID. In fact, it's quite a nice excuse, isn't it, at the moment, to normalise quite a lot of different behaviours.
Absolutely. Yes. So that's the interesting thing, Ruth. One of the interesting things as an old age psychiatrist is that when I started 25 odd years ago as a consultant, and I was sitting there with the initial assessment form, I was putting alcohol use in the I started off by putting it in the past psychiatric history. Of course, that's not going to do any good. People will think, what, you're calling me an alcoholic? Then I put it in the past medical history, and then people are thinking equally, what do you think I've got? Do you think I've got a medical problem? Do you think I've got alcohol dependence? And funnily enough, the thing that I did 15 years after I started as a consultant was put it in the social history, because the thing about alcohol is that it's part of our normal everyday lifestyle. And what I do is I put it right at the end of the social history. So when I've done the activities of daily living, the personal ADLs, the instrumental ADLs, I then tag it onto a typical day. So it's right on the end of a typical day. How do you spend your day? Do you ever go down that? What's your local? Do you ever have a drink now and again? And it's that non-stigmatizing, non-confrontational, non-judgmental approach to assessing alcohol use that I think most psychiatrists, apart from addiction psychiatrists, actually get. And I think GPs get that as well.
Absolutely. And I think for me, the other key question that I quite like is can you remember the last day when you had no alcohol?
Yes.
And that's quite a telling question, because if people are really struggling to think back that does suggest dependency drinking. But if they say, oh, you know, I was on holiday with friends and family 2 weeks ago, but we ran out and we couldn't get to the shops, or, you know, whatever, if they can remember the days when they didn't have alcohol, that for me is a telling one. And that would probably lead into a conversation about, so if you don't have alcohol, what happens to you on the next day? Or what happens to you, just to try and start to tease out, is there any element of dependency? And the question back to you would be, does dependency look very different for older people?
Really, really good questions, and this is one of the things that I explored in some of the various articles that we've published. That with Alana Crome, who was with me, we were co-authors on our Invisible Addicts. We sort of set this whole agenda, really kicked off about 10 years ago. And one of the interesting things about dependence in older people is that there's several factors which mean that you're very often not going to be able to detect dependence. I mean, for example, people can be dependent at very low levels of alcohol use because of their sensitivity to alcohol, because of the volume of distribution. What's called the fat water ratio is increased, so the volume of distribution in the blood in which the alcohol is distributed is lower. People might say they've given up their hobbies or their interests and sort of role abdication, if you like, and that could be because they didn't have any interest in the first place. So that all those 6 or 7 criteria for alcohol dependence are just sort of blown out because they don't fulfill the typical criteria for older people. So it's very often on a home visit, it is things like the bottles lying around, and don't forget it's the home carer that collects those, brushes those away, puts those away and clears those away at the end of the week, and not the GP or the psychiatrist. It's talking to family members. It's getting that kind of insight into what alcohol means for that person. And as you say, are they drinking every day? And I think that brings us on to the next thing about what screening tests are used in general practice. So, for example, the Audit C is a very convenient, quick and easy, valid and reliable assessment of alcohol use in older people. And that has 3 components. One is how often people drink. The second one is how much they drink on each occasion. And the third one is, do they ever binge drink? So, Ruth, I was going to ask you, what sort of assessments would you do formally for people in primary care?
Yeah, so we do use Audit C, but I'm not sure that it's necessary. GPs tend to be very bad at using formal screening or formal. I have to be honest, our receptionists were much better at it, in that it's part of the new patient health check. We also, as our nurses, they're much more likely to have the ticks box that needs them to tick it, so they will ask the questions. I think we generally would be, it's very similar to the risk assessment. It will be us then having to do once it's been detected by some other party. I suppose we would maybe see it, we do a lot of screening for older people. You know, we'll be doing routine CKs if they've got chronic kidney disease, so we may well stick an LFT on there. We might see other changes, and then we would have to be alert and start having a full blood count where the MCV is high might trigger a thought to start screening. I tend to, as I say, the questions I generally use would be the ones I've mentioned, but it is important that we try and use proper validated tools as much as possible. I understand that.
And I think that might bring on to us the last point, because we've got 2 minutes to go, and that is about a brief intervention. One of the things, so I did an MSc in addictions because I just didn't want to see more people dying and being turned away and just ending up homeless or being evicted or getting liver damage or dementia. And one of the things that I'm really surprised about when I do my kind of training around the country and also in other countries as well, is that a lot of psychiatrists who haven't done jobs in addiction, because they don't teach you this in medical school, is what is a brief intervention. And it's as simple as you know, Ruth, it's as simple as a 5-minute conversation where you ask people's permission to talk about their alcohol use. And that involves looking at the various parameters with regard to harm. So the screening questionnaire, so do they score 4 or more on the Audit C, their LFTs, have they been having falls, all sorts of different biopsychosocial health parameters that help you to get them to understand about how they can make changes to their drinking behaviour.
I think brief interventions where we're at, isn't it, in general practice?
That's right.
And to me, it would be just the, what do you think about your drinking? Is it good?
Yes.
Is it bad? Do you want to change it? And then take it from there. Because yeah, brief intervention. You soon learn if somebody wants to be involved in change or not with that brief intervention. I think Linda's going to cut us off and start asking questions soon, isn't she?
I'm going to cut you off because it's a convenient moment. So we've 2 questions which are actually linked. And the first is, cognitive impairment and high alcohol intake is a challenge. Patients don't always remember or agree that cutting down is needed, or they initially agree it's a problem but forget later that they need to make a change. Any ideas? Just regular contact and support, for instance. What do you do?
I could talk for an hour on this because I've done a training program on this, but just to do it within 2 minutes. One of the advantages that we have, I suppose, with things like depression, particularly things like dementia, is that it is a dual diagnosis. So you can't admit someone purely on the basis of their substance use or misuse under the Mental Health Act. So very often, if there's a risk purely associated with alcohol, you can't use something like that. You can't use a legal framework, but you can under the Mental Health Act. So if someone's self-neglecting to the extent that they are forgetting to eat, they're drinking, they're damaging their brain, they've lost their insight, they're being aggressive or whatever, we can use that. But I have to say it's very difficult to quantify alcohol use for someone who won't tell you, and very often you rely on external sources such as family or friends or neighbours, and unfortunately also sometimes the local ambulance service, social services and housing.
Any comments on that, Ruth?
I would agree, but I think, well, everyone is generally quite bad at working out units. There's very few people. And what's a little tipple and a little tot? When people are having half whiskey, half Horlicks, it's hard to work out what's actually being drunk. But you're absolutely right. I'd agree. It's corroborative information that we need.
There's a follow-up question to that, which I really like Narida's question on cognitive impairment, but how do you unpick cognitive impairment from depression? And how do you approach treatment of depression in the context of cognitive impairment? Now that's a question that's not directly linked to alcohol, but I think I understand where the person's coming from. In secondary care, I've seen patients with dementia who have low mood but are too impaired to engage in formal psychology. Any comments you'd like to make on that?
Did you want to say anything, Ruth, first?
I think that's a secondary care problem.
So I think so. A really good point. I'll tell you why. Because when alcohol misuse really kicks in, it damages the frontal lobes of the brain much sooner than it damages things like language, for example. And very often, even in the late stages of alcohol-related dementia, language is preserved. So there are some giveaway features, clinical features that you can use to distinguish, say, dementia from depression. One is, the point I was trying to make was that if you get someone who's lacking in motivation, it's very difficult to tell, is that depression or is it cognitive impairment? And the way that I use to detect the difference is like any clinician, any psychiatrist, and that will be the emotional tone associated with that sort of description of how they're feeling. So if someone's unmotivated, and they've got depression, very often they will talk about, whether or not they've got both together, they will talk about things like feeling low, and particularly in older people, as you know, the psychiatrists listening, feeling bored, feeling lonely, feeling fed up, feeling that they want to die, suicidal ideation, that sort of thing. So it's more the emotional tone and the emotional mindset and the cognitive distortions and negative automatic thoughts that very often help to distinguish between alcohol-related cognitive impairment, stroke dementia, and depression associated with alcohol misuse.
Okay, thank you very much, both of you. That's great. You were taking me back to the days when I worked as a consultant in alcohol problems, and I had to manage people with Korsakoffs in the community, which is another story all in itself. So we've now got a clean sweep of the presenters, and I'd like to ask Hazel and Mummy to introduce themselves, and we've moved on to the fourth segment of the history.
Hi, thanks, Linda. I'm Mani Krishnan. I'm an old age psychiatrist. I'm also the chair of the Faculty of Old Age Psychiatry, and it has been great to have this discussion. I think we should do it more often, and I'm going to hand over to Hazel to introduce herself.
Hi, so I'm Hazel Everitt. I'm a GP in Southampton and Professor of Primary Care Research at Southampton University, and I've got a special interest in managing insomnia in primary care.
Yeah. Could you go back to the previous slide? I think it's the same slide. We're just going to look at it. Yeah. So it's about Mr. O'Neill, who says he takes a tot of whiskey to help him to sleep. Otherwise, he lies awake, tossing and turning. And he's clear that if he's going to reduce his alcohol, he needs something for his sleep. And he also gently slips in saying that his sister gets nitrazepam from GP. So what are your thoughts, Hazel?
So this is really common, isn't it? And it's a lot to unpick, and you've heard quite a complicated medical history already. So I think we have to go back to basics, and we have to think about listening to the patient, taking into account all the comorbidities, and trying to find out exactly what his sleep is like and what his situation is like at home. So, you know, his medical history had osteoarthritis in it. He may have pain at night that's causing him problems. Obviously, his alcohol consumption could cause him problems. And we've got to explore those comorbidities to see whether there's something we can do to manage those to help any sleep. If you're elderly and you just have a tot of whiskey at night, I don't think that's necessarily a potential problem. And I wouldn't necessarily try and tell people to stop. So it's doing that risk assessment as we were talking about previously. And then it's looking at ways to help him manage the situation. I was going to hand back to you to maybe talk about some sleep hygiene, I think.
Yeah, I think, again, it is common that especially our older adults, they do complain a lot about sleep. Sometimes we need to think about what's the amount of hours they need sleep. Some of them who are retired may not be having a lot of physical activity or even frailty. They may be resting, they may be snoozing during the day, and then they probably do several hours of sleep episodes during the day, and then they'll say, "Doctor, I don't sleep at all." So sometimes it is useful to have. We talk about sleep hygiene, and I'm sure we discussed at some point, Hazel, about CBT, some kind of a cognitive therapy, as well as explaining to them what is that sleep. You know, especially a lot of our older adults watch TV in bed, and reading book is one thing, but watching or big nowadays, most of them have 55-inch TVs, so it's a massive screen. Watching TV, having a drink at night, which will get them to wake up to go to the toilet because they could be incontinent as well. And also having that sleep routine is really, really important. And sometimes people say, I do it all. And then if you actually question them, they actually don't do that. And then, and also they do accumulate medication. Like he said, his sister is having nitrazepam. So I do worry about benzo medication. We will talk in a bit, but what are your ideas about benzodiazepines for sleep?
Yeah, so I mean, benzodiazepines, we all know, were really overprescribed in the past, and we've had huge problems with addiction and dependence and all the falls and the other side effects that they give. So we do try to avoid prescribing them in elderly people and in anyone really in general practice these days. The problem is what's the alternative? Occasionally, if there's an acute situation, then short-term use as per NICE guidelines seems very reasonable, but otherwise we're thinking about alternatives. And I think going back to reinforcing and checking the sleep hygiene is really important, giving proper material for that, and then finding out what the sleep's like. So some sort of a sleep diary, if you can manage in this age group, would be really helpful, or at least a really detailed history. And then we do have now access to CBT for insomnia a bit more in from general practice than we used to. So the IAP services across most of the country now has a greater remit for managing long-term conditions, and that's both for the depression and for insomnia. And obviously CBTI, where you can really discuss sleep in in detail as part of a CBT program, and think about things like how to manage it and the thoughts, because as you say, a lot of older people don't need as much sleep, and it's them understanding how much they need and the impact it's having on their lives, and what we can do. Then we get on to other medications, and I've done quite a lot of research looking at antidepressants for sleep, and in fact the evidence is very poor. So we've done a Cochrane systematic review, and although quite a lot of us prescribe low dose amitriptyline or trazodone or all sorts of things for sleep, the evidence out there is not good. There are more trials coming through, but at the moment we need to think very carefully about those sort of things, because obviously a lot of them have similar impact as far as side effects and problems to some of the benzos that we're trying to avoid, and the Z drugs. What are your thoughts on that?
Yeah, I think again, earlier on you mentioned about, number one, I do have significant worry about giving this low dose antidepressant for sleep, especially in older adults that do tricyclics. They either do amitriptyline, trazodone, sometimes the promethazine seem to be creeping up. Let's not forget they are older adults. They do have heavy anticholinergic burden, and they might actually cause confusion. And there are studies that it can even, provide some early signs of dementia if they're on long-term use of tricyclics for sleep. And the other thing I worry is about, even though patient may be on benzo for a long time, and as with the policies, sometimes people just abruptly stop the antidepressant, and I find that really worrying. I had a patient who was on 3.75 milligram of zopiclone for about 10 plus years, and then because they moved from one surgery to another, so they abruptly stopped the medication. Patient went into frank delirium. It took 6 to 8 weeks to bring her back to her normalcy. So even though benzo is not good, but dropping it like that is not at all good. So we talk about benzodiazepine equivalent. 0.5 milligram of lorazepam is equivalent to 5 milligram of diazepam, or 1 milligram of lorazepam is 10 milligram of diazepam. So I do think that if we need to stop it, it will be 1 milligram a month. It may take 10 months, but we do need to support them. I think that's one thing I'm really keen. And you mentioned about the CBTI, are they widely available, Hazel?
Yeah, so it's becoming more available. We all know how there's waiting lists for IAP and in the NHS for various things. There should be some posts going on soon. There is online CBT available if somebody's competent to do that or has a family member who can help them as well. The two ones that seem to be most available at the moment for online CBT for insomnia are Sleepio and Sleep Station, and those you can link to through the NHS links I've put on posting. There is variable access depending on which area of the country and in which CCG or has paid for them, basically. But there are various options to start CBT, and obviously even if there isn't specific CBT for insomnia available through IAP, then it may well be that normal CBT with focus on long-term conditions and managing things could help these people. So I think the other thing, of course, is the ongoing support of a regular person. Now, this person didn't seem to know his GP very well, and that if there is a GP or a social prescriber or a practice nurse who can see him more regularly and help him move through some of these things, that may well help with his sleep, and we may not need to resort to medication.
Yeah, another point just to mention about his environment, isn't it? Like, again, older adults, too heat, too cold, new places. You already earlier on mentioned about pain, other physical symptoms, or family members, grandchildren. So there are a lot of things that could affect their sleep as well. So having that holistic assessment of what is the sleep kind of a current problem. And there are, I have seen patients who would say, all my life I've been a shift worker and I always went to bed such and such time and woke up. Suddenly the other family come and say, my dad is not sleeping, but he never slept for 45 years. So it is about getting that comprehensive history and then trying to, tailor the treatment that will be important rather than just jumping to prescribe medication, I think will be my view.
And there is, we've just posted something about the REST project on the chat as well, and that's quite useful because that's a great resource about managing insomnia in very brief consultations. It was set up for GPs, but would be useful for all clinicians. It's got lots of learning about managing insomnia with people and how you can do very brief interventions, which we were talking about earlier, for insomnia within very short consultations. So if people want to look more than that one, it was done a while ago, but it's still all very relevant, and that should be open access, I think. It is very difficult, and it's trying to work out what you have in your region to support people and the best thing for each individual, isn't it? And I think that's what this whole chat has shown us, is that you need to ask the questions and you need to take everybody in a holistic way.
I'm going to stop you there. We have a question about Z drugs. The recent BAP pharmacy guidelines have advocated Z drugs can be used quite safely long-term for treatment of primary insomnia, if used within recommended doses. Obviously, there are concerns about sedatives in adult population with comorbidities, but for those it can work for, has this translated to common practice in primary and secondary care? Now, I would have thought the Z drugs are a little controversial for longer term use, but they certainly were when I was practicing. I'd like your thoughts.
Do you want me to go first?
Yes, by all means.
I think the guidelines is very easy to say it could be used. I think Hazel pointed out it is about short term and long term. The biggest problem we encounter with our older adults are, there need to be a stop date, but so unfortunately, it's easy to start them on Z, but not exploring other points. So sleep hygiene as a leaflet in my CMHT, we will be giving it to every single patient who hits our service. So if we tried it, and then again, I'm not completely against it. We do prescribe, as Hazel again mentioned, but it's about who puts the stop date, who cuts it off. Otherwise, paradoxical agitation, confusion, movement disorders, all those things can happen on a long-term basis use of benzos. And one of my passionate subjects, delirium, it's quite common. And as they get forgetful, they may take overdose, not overdose for self-harm, but extra doses. Hazel?
Yes, it's very interesting, isn't it? I think it's a big issue. My personal opinion is Z drugs are not the answer. This is the short answer. But I think, in certain circumstances, you have to manage the situation in front of you, but we don't want to create dependence. And I think, time and a relationship is really important to working out what's best for each patient. I think the side effect profile is not that dissimilar from Z drugs to benzos.
One last question. A question about, is Metazepine a reasonable option to both aid sleep and appetite stimulation?
Yeah, okay, can I answer that? Okay, so I have no shares with the company, but I think it is, again, as an old age psychiatry, it is one of my favorite drugs if patients are quite thin, frail, and having major problem with insomnia. It does definitely help, but be mindful. The lower dose is more helpful for sleep than the higher dose, because in adult, you will start with 30 milligram, but 15 milligram actually causes more sleepiness because of the histaminergic properties. This is an idiosyncratic reaction. I was teaching my medical student daughter. And what you need to be mindful, in fact, in India, there is a 7.5 milligram dose available. It causes even more sleepiness, it seems. So if older adults are coming with mild depression, sleep problem, and appetite issue, yes, 15 milligram metazepine is a good trial. But the moment you push it up to 30, they might say my sleep is getting worse. So always be mindful of that. But otherwise, if there is a combination there, I would say these are the two side effects. It's a really good effect for older adults.
Anything you'd like to add, Hazel?
Yes, it's interesting. We don't have a strong evidence base as far as Cochrane systematic review evidence is concerned for metazepine for sleep, but I think it's probably one of the better bets at the moment, but we're still waiting for the real evidence to know.
Right. Okay, we are now 1 minute from the end, and I'd like to thank everybody for attending. thank you so much for signing in on a Wednesday evening, and thank you to all the presenters. This will be recorded and will be available. We'll publicise how it's available. And please let us know what your thoughts about it are and whether you'd like further discussions of this sort. I just think it's been marvellous to see psychiatrists and GPs asking each other questions, and I've really enjoyed it. And so thank you, everybody, and thank you very much to the staff from the RC Psych for helping us run it. Thank you.
Thank you so much. Thank you. Safe journey home or to your kitchen.